Good afternoon and welcome to the OR Today webinar series. We're excited to have over 280 registered attendees for today's webinar. I want to remind you today's webinar is eligible for one continuing education hour. The post-webinar survey and certificate process are now automated, so the survey link will be included in the follow-up email, which you'll receive about an hour after this webinar has finished. Once you've completed the survey, you'll be able to download your certificate immediately, and one lucky attendee will win an Amazon gift card for completing the survey. Okay, let's kick off today's webinar by giving an OR Today Live surprise pack to the attendee that can tell me the answer to the following trivia question. Today's sponsor, 3M, is headquartered in Minnesota. Name the university where the first open heart surgery and the first bone marrow transplant in the US were performed. Answer now using the questions feature on your dashboard. While you're answering, just a reminder to save the date for our 7th annual OR Today Live Surgical Conference, which will be taking place from August the 16th to the 18th next year at the Omni Interlochen Hotel in Denver, Colorado. Join us to discover new opportunities, broaden your knowledge, and exchange ideas. And for more information, visit ortodaylive.com. Okay, let's see who the winner of our OR Today Surprise package is, and it is Liz Kiffmeyer. Congratulations, Liz. Of course, the correct answer is the University of Minnesota. OR Today would like to thank our sponsor, 3M. At 3M, they apply science in collaborative ways to improve lives daily. With 33 billion in sales, their 93,000 employees connect with customers all around the world. Learn more about 3M's creative solutions to the world's problems at 3m.com or on Twitter at 3M or at 3M News. Our presenter today is Kimberly Prinsen, Technical Service Specialist in the Medical Solutions Division of 3M. Kim, you may begin whenever you're ready.
All right, thank you, Linda, for that introduction, and welcome everybody to this webinar today called Think Skin Deeper, Preventing OR Complications. As Linda said, I'm a technical service specialist for 3M Medical Solutions Division, and my background is in OR nursing. So I've had over 36 years of experience in that field, and certainly it's been a privilege to have that experience as well, all the way from when I started out as a scrub and circulating nurse through towards the end of my career where I was director of surgical services. So I've got quite a soft spot in my heart for surgical and or the perioperative practice of nursing. So this topic is going to kind of look at things a little differently, and I'm very excited to talk to you about it today. Just to review our objectives, we're going to look at the structure and function of the skin and its relation to health and disease. We're going to look at preventable OR complications and then strategies to reduce those complications. We'll spend a little bit of time on wound management as well, and kind of look at how we can consider the skin in terms of how we protect our patients from complications. So we'll get started. So the good news is that the most recent data from the ARC, AHRQ, tells us that there's a decline in hospital-acquired conditions. This information was gathered, and it's kind of the most recent information that showed data from 2014 to 2017. And what we see is that we've done pretty well overall, but we still have an increase in pressure injuries. And while surgical site infections remain at zero, it remains unmoved. So that tells us that we really have some work that we can still do in terms of helping reduce complications for our patients. In addition, the most recent information from the CDC website tells us that on any given day, 1 in 31 hospital patients has at least one hospital healthcare acquired condition. So the question that I'm going to ask you is, what was your hospital census today, or what is your hospital census today? And that kind of makes us stop and think about, you know, the patients that we have in our care and what might be happening and going on with them. So today we're going to look at preventing OR complications from a slightly different vantage point, and that's the patient's skin. Skin is the most common denominator in all of the processes that we're going to be discussing. And if we look deeper, kind of below the surface, if you'll, so to speak, of the skin, we'll have a better understanding of how we can protect the patient from OR complications. So first, I'd like to start with a few fun facts. And if we were face-to-face, I'd be asking you these questions. But first of all, the one fun fact about the skin is that it is the largest organ of our body. And if we want to know how much the average this total area of skin on the average adult, that's been kind of an interesting data too. For the average adult, there's about 20 square feet of skin on our bodies. And then in terms of weight, the approximate weight of our skin is between 25 and 30 pounds, and that really depends on male and female, obviously, and also your just overall size. And then I think the other one that's most interesting is if we ask, what is the number of skin tones that we see globally? And when I ask this question, most people say, well, it's infinite, and I would tend to agree with that. But if we go by the Pantone skin guide, we have about 110 skin tones that we have on average. So that's a few fun facts. So when we look at the skin, we really think of it as kind of the mirror of the body's function or dysfunction. It has the power to really tell a story and to help us spot factors that can really impact health and healing. So if you think, for example, you're caring for a patient in the OR, maybe you're walking into the room to give a break and they're getting that patient ready, and you look over at the patient and you notice that this is a 55-year-old male who's going to have a hernia surgery. And without even looking at his chart, you can look at his skin and he can tell you a lot. You can tell that this particular patient has really dry, wrinkled skin. The color's kind of dusky. And it makes you think, he's on 100%, they're ventilating him, so they're controlling his airway. He should be a little brighter. So is he a smoker? Does he have some cardiovascular disease? Those are some kind of things that you can tell just by looking at that skin. And obviously hydration might be a concern if we know that the patients are NPO, but if they have super dry skin, hydration may be a concern as well for this person. So you kind of can tell a lot just by looking at somebody. And in general, clinicians really get concerned about skin when it becomes broken. So for the purpose of this education, we're really going to examine what we can learn about skin, both visually and also by understanding more about the skin's function itself. That will help us better prepare patients for surgery and reduce that risk for OR complications. And the reason we're going to do this is because the skin is really our first line of defense against any injury or infection. It's kind of the the moat around our castle. It keeps things, it protects us from many things. And so what we need to understand is when we put somebody in an environment such as surgery, or even when they're critically ill in some way, then we have to really take over that role of that greatest line of defense and support it when it can't do that support for us. So we're going to look at the anatomy of the skin. Just basically, it's, the skin has 3 layers. We know them to be the epidermis, the dermis, and then the hypodermis, or the sub-Q tissue. The epidermis is really the outermost layer. You can see that of the skin. It acts as that physical barrier, preventing any loss of water from the body, and it's really kind of that chemical biological barrier for us as well. And we know that the thickness of that skin varies according to the body site. If we move down to the dermis, that's directly below the epidermis, and it's comprised of fibrous connective tissue, and it's considered kind of that supportive layer of the skin. And we know that there's a great deal of collagen, elastin fibers. Our blood vessels are there. There's nerves and inflammatory cells that are there. So that's our hair follicles and our sweat glands kind of originate in this area as well. So that's our second layer. And then our subcutaneous tissue, or the hypodermis, consists mainly of fat cells, and there's some nerve and blood cells there as well. And within all 3 of these layers, there's numerous types of cells that each have specific roles to play, and these roles play across multiple functions. Does that seem kind of straightforward? Yes and no, because what we'll learn here in just a moment is that the skin really has multiple functions. So for this particular information, I used the structure and function of skin. It's Rook's textbook on dermatology. And what it tells us is that identifies really 10 functions of the skin. So the first one, of course, we talked about already, is protection. The skin is really that dynamic protective barrier between the human body and the external environment. The next function that it has is really our sensation. There's specialized receptors that detect touch, pressure, heat, cold, and pain. And the third function is the thermoregulation. It's really the skin's primary thermoregulatory mechanisms are really circulation and sweating, and these are actually activated by those receptors that we just talked about. Another function is immunoregulation, and that really is what protects our body against invading microorganisms and antigens. So think about a time when you have some kind of an irritant on your skin. You've got some pollen or some kind of a allergen that's been on your skin, and your skin turns red and itches, and it's telling you that something's there that's irritating it. So it kind of gives you a cue that something's going on that you need to pay attention to. In addition, our skin's ability to self-repair is really an essential survival process. So we can either repair by regeneration or replacement of damaged or lost tissue with more of the same. And then there's also connective tissue repair, and that's at the time in this process, that's where we are replaced by scar formation. So two types of self-repair occur. And you think about this is really impactful, especially when we have burn patients, right? I mean, when the skin's gone, we know what risks, the great risk that those patients are at when we've taken away that particular ability and protective line. Another function of the skin is metabolic. Think about the vitamin D synthesis that occurs in our skin when it's exposed to sunlight. That's one of the metabolic functions that it has. We also the skin can also store body fluids and nutrients, and we know that that's due to the tight packing of cells in the stratum corneum, that helps our skin really retain necessary body fluids and moisture, and it protects us also from absorbing external fluids or liquids. Absorption and excretion and secretion. Think about what we excrete from our bodies, right? CO2, water, sebum, sodium, potassium, those are all things that we secrete. And in addition, we also absorb oxygen in limited quantities as well from our external environment. The other thing I think is really important for us to understand is the function of microbial symbiosis. And that's really kind of talking about that microbiome that lives in and on our body. And that really plays a critical role in the balance between health and illness and the human being itself. And we'll talk a little bit more about that later. And then finally, the 10th function has to do with identity and communication, right? So it plays an important role in social communication among humans. Think about the identity from a cosmetic perspective, also from identifying marks or moles or scars that we might have, and also if there's damage in our skin itself, that can result in both a functional and physiological impact as well as a psychological impact. So it plays an important role in function overall as well. So fortunately, this complex organ functions amazingly well when people are healthy. And however, when the patient is compromised in the state such as under anesthesia or they're critically ill, as we talked about a little bit earlier, we again need to understand how we can support the diminished ability of the skin to protect us and to prevent the skin injury before it occurs. So that's some of the stuff that we're going to look at. And we're going to look at evidence-based practices that we can really use to help protect that great line of defense that we have and call our skin. So we're going to look at some things we're going to look at today as reducing risk of pressure injuries and skin injuries, reducing the microbial load, maintaining normothermia, and skin surgical wound management. And we're going to talk more about understanding to understand why these strategies are effective and to make sure that our staff does as well. The why is behind all of this is really what drives compliance to best practice. And so I have a lot of resources on my slides. If there's something that you're interested in, you can let Linda know via your survey if you would like a copy of them, because there's lots of resources on there that you might find interesting. But I'm not going to use a ton of statistics and studies. I'm going to talk more about those basic practices that we should understand. And then when you're listening to this, think two things. Think what you and your team are doing well right now, and then think about what you might want to add to improve your patient care and patient outcomes. So the first thing we're going to talk about is reducing the risk of pressure injuries and skin injuries. And when we look at the skin's function, what we really know is impacted from a function perspective related to pressure injuries has to do with the protective function of our skin, our sensory perception, and our thermal regulation. And these are specific concerns when patients are either under anesthesia or are in some way unable to respond, perhaps are critically ill, that type of thing. So they no longer can control or respond to the skin's cues that it gives us. So we're going to do our first polling questions, and I will read it to you and then have you respond. Do you have a skin integrity program for surgical patients? Yes, no, or uncertain?
Okay, people are voting. I will now close out the poll. And you have 38% said yes, 33% said no, and 29% said they're uncertain.
Okay, thank you for that. And I think we have one more question here. Oops. And the next question is, what percentage of patients in the OR are affected by pressure injuries? So up to 5%, up to 15%, up to 45%, or 0%?
Okay, I'm closing the poll. We have 13% at say 5%, 48% at 15%, 37% at the 45%, and 2% at 0%.
All right. Well, the answer is up to 45% of patients that are going or undergoing surgery can be affected by pressure injuries. Now, that is something that in recent journal articles, the one I just read that came out, I think in September, reported a rate of a 57.4% incident of pressure injuries in surgical patients. So we actually see that in all the hospital departments, the highest rate has to do with surgical patients. Typically, we think it might be ICU patients, which really they are more the 10 to 41% range, and other home care, those areas are a little lower. So this is really important information for us to understand. And it makes sense when you think about it, because when patients are in surgery, they're immobile, they're unable to voice discomfort, right? They can't move to relieve any pressure. And then sometimes they're positioned in a way that doesn't really distribute weight well. And then the effects of anesthesia can really impact our muscles and our vascular system in terms of relaxation, and then of course anesthesia in terms of vital sign changes. So it makes sense if you really stop to think about it that this is really an important consideration for us. We also know that with pressure injuries, we see all sorts of things, pain and suffering. There's an increased rate of surgical site infections with patients that have pressure injury. We know that it can add length of stay as well as an increased cost. The average cost is around $10,700, but I've seen some data that supports a $41,000 increase in cost depending on the complications that might arise. And of course, we always need to consider the hospital reimbursement. So pressure injury is considered a preventable event, especially if somebody comes to us without one. So that's something that can cause a penalty for us in terms of reimbursement if a patient ends up with one. So just the National Pressure Ulcer and Advisory Panel, they actually just changed their name to the National Pressure Injury Advisory Panel. They define a pressure injury as localized damage to the skin or underlying soft tissue. It's typically over a bony prominence or related to medical or other devices. Your skin can be intact or open, and it can be very painful, of course. And we're going to talk about what causes it and some of the conditions that play a role in that as well. So if we look at pressure injury, how it forms, our typical or traditional thinking really looked at a ischemic induced damage cycle. And really that really meant that there was pressure. It caused capillary occlusion, which caused ischemia, and that led to hypoxia, accumulation of waste products and PHG, and then tissue death. And that really is kind of how we thought about pressure injuries or pressure traditionally. But we know that certainly the amount of pressure and the amount of time that the tissue is exposed to it is important, and then that tissue tolerance, right? And so we remember, you're probably very familiar with the Braden scale, kind of based on the Braden-Bergstrom framework of tissue tolerance, and that really talked about all those things that play a role in developing that play a role in the development of pressure injury. But this traditional thinking, this ischemic induced damage cycle itself, is not necessarily a quick process, so it didn't really help us understand what's going on in the OR that might be different. And so in the 2000s, there was some additional work that was done, and that led us to some new thinking about direct deformation damage. And those studies used a variety of data to collect information. There's such as MRI imaging, ultrasound. There is analysis of the cells, the biochemical markers in cells and cultures. All those things kind of together showed us that there's another way to understand and predict how tissue will behave under certain conditions. And in this tissue direct deformation damage, what happens is that the pressure itself results in deforming the tissue itself, and that leads to cellular deformation, and that cell structure sustains damage to the cytoskeleton itself, and that really causes damage. There's plasma membrane to the plasma membrane, there's perfusion and lymphatic drainage, all that's disrupted, and that then can lead to eventual cell death. And this particular process can occur within minutes. Really depends on the amount of pressure and some other patient factors. So that really helps us understand that it's really a faster process, and helps us understand how it may be related to surgical patients. So it's just good to have an understanding of that actual etiology of pressure injuries. So the thing to keep in mind is the route from the OR can have many stops, right? There's lots of things that can happen to that patient before they even hit our OR suite, and not to mention what might have happened at home, how long they were incapacitated, how long they waited prior to surgery. All those things can play a role in what might happen to that patient's skin during surgery. And so there are risk factors that we need to consider in and out of the OR, right? The surgical position itself, the time on the table, devices that we might use, what kind of supportive surfaces do we have our patients on? Blood loss, hypotension, all those things play a role, hypothermia, the age of the patient, just the overall status of that patient. So all these factors play into how that patient's skin is going to react throughout that surgical process. And so when you think of a pressure injury, these may be some of those images that you think of, right? But in the OR, it can present differently. It can present in two ways. It can either present as deep tissue injuries or medical device related pressure injuries. And so let's first look at the deep tissue pressure injuries. So these sometimes they have been mistaken as bruised areas or burned areas. And really what's happening is that you're having some pressure injuries that occur in the deep tissue. And so you're looking from it, the injury is internal and it's presenting externally. And you may not even see it right after surgery is over, but there's something we'll talk about in a moment that you can kind of check for. So it can be intact or non-intact, but really it's an area that's persistent and it's not non-blanchable. So the coloring may be deep red to maroon. And again, these can be sustained either from intense or prolonged pressure injuries. And then there's always shear force at that bone muscle interface. That's typically what's causing this particular injury. And of course, medical device related injuries are also cause damage to underlying tissues as well by either the pressure of the device itself or from friction. And these type of injuries are mainly seen in the head or neck. In one particular study, they gave us a rate of between 45 and 70% of the time. And that can vary depending on the study that you're looking at. And then also the feet or ankle area as well. So I highlighted some of the common devices around the body that we encounter or secure in the OR, right? ET tubes, O2 masks, plates, or excuse me, cervical collars, Foley's, external fixator. Those are all some of the things that we use in the OR. So we need to understand, what's the best way to protect that patient from a device injury. How do we support it and how do we pad it and so that it doesn't cause a problem to that patient. So the ultimate cause of pressure injuries, of course, is pressure. And the intrinsic and extrinsic factors affect the ability of that skin to respond to that pressure. But ultimately, it's the pressure occluding the vessels or causing damage to the cell structure that really begins that whole cycle. And then the other thing that needs to really occur is shear. So shearing is really when the skin is pulled in one direction while the bone slides in the opposite direction in the opposing manner. And it's kind of that, it's where the muscle cells, that kind of bone tissue interface. And the reason why they're more sensitive to damage is really that longitudinal arrangement of the muscle fibers. And that's really what aids in causing problems as well. So pressure, shear, and then finally friction. So that means the surface where that patient is laying on stays the same. So you've got three different things kind of working against you, and we know that pressure in combination with shear and friction can result in pressure injuries. And so think about this particular patient and what they've got going on. They've got the pressure of just the gravitational pressure on a surface. And then if they're in a beach chair position, for example, they're sliding down and then the surface of the bed is staying same and they're sliding on it. So all these things combined cause a problem for that patient. And one that comes to mind is a patient that we did in surgery, a shoulder patient that we had hadn't planned for the surgery to go as long as it did. They were in a beach chair position, and it lasted what we thought was an hour, ended up lasting about 5 hours. And that patient ended up with some deficit after the surgery because of positioning, and most of that occurred right in the sacral area as well. So I mean, these are really important things just to keep in mind as you're positioning patients. So what do? We need to manage that microclimate. And that has to do with making sure that we need to understand that moisture really exacerbates the effects of friction and shear. And we think about the preps in the OR especially, right? So that's why one of the reasons why we protect the patient by applying either a towel or some kind of a absorbent pad, a Chuck's pad, to collect any fluid that might run or pool. And we want to make sure as well that they're not that we protect from any irrigation or anything pooling around our patients, because that can really impact that patient's skin. And the other thing that we need to consider is the temperature. So when we're talking about temperature, we need to make sure that our patients are not hypothermic or they're not hyperthermic, right? So we don't want them to be too cold or too hot. We want them to maintain normothermia. And the reason is because if they're hypothermic, that causes vasoconstriction and decreases the perfusion at that cellular level. And we know that with each degree of hypothermia, below hypothermia, which is 36 degrees centigrade, we increase that risk of pressure injury by 20%. Likewise, we don't want patients to be too hot, because if they're too hot, then we increase the moisture at that skin level, which we already talked about, causes problems. And with moisture, we also see an increase in frictional forces. And also when someone's too hot, they increase their metabolism, so they use more oxygen. And that we already know that because there's pressure applied there, we know that perfusion is already restricted. So the important thing is really to maintain normothermia. So how do we prevent pressure injuries? Well, we do a couple things. We need to assess skin integrity, and there's some specific tools for the OR. I'm sure many of you are familiar with the Braden scale, but that's not specific for the OR patients. We want to really look at either the Monroe scale or the Scott's trigger tool. These are two that have been designed for OR patients, and they're really there's some great resources that I would recommend you looking at if you don't have a program in place. And the AORN guidelines, they have a toolkit for a skin integrity program, and they go through all the different things that you should be doing and assessing your patients on as you're getting ready to kind of do some skin integrity programs development. So after you assess that patient and see kind of what that baseline is, then you want to make sure that you're understanding that smart positioning for that patient as well. So when we think about positioning, we want to look at, our basic equipment. So, how do we customize that positioning for that particular patient and their needs? So according to Scott, the conventional standard OR table, which is about 2 inches thick, may be considered hazard for high risk patients. So they recommend that we have at least 1 inch of mattress or padding between the patient's skin and then that hard surface of the bed. So if you think of, somebody that's over maybe a little larger and they're on our conventional or table mattresses, that's not going to provide the support that they need. You need to understand, what type of positioning devices that you have. Are they gel? Are they pressure redistributing devices, foam? Whatever they have, they should be specific for that purpose. Gone are the days when we used rolled blankets and towels and IV bags for our positioning. We really need to pay attention to what we're using for positioning and make sure that we make sure it's in good repair and is appropriate for our patients. We want to make sure that there's no layers between that device and the patient themselves, and that if the position itself requires that we use some prophylactic dressings over those bony prominences that kind of help redistribute pressure of that skin. Also, when we reposition, we talk about we've been told that we want to reposition a patient if possible. So you think about that for the OR patient. What does that mean? It's not like we're going to take them out of lithotomy or move. Hey doc, I got to move the patient now because they've been laying here too long. But repositioning can be as simple as turning the bed a few degrees, few degrees one direction or the other, just simply airplaning them slightly one direction or the other, just to kind of shift that position and pressure off of one area and redistribute pressure. So those are some ways that you can do that. And then of course, I think it's important to understand that our staff, we don't want them to be leaning on the patient when they're up against up on the sterile field, that they're making sure there's no additional pressure being placed at the top of that patient by somebody leaning or a piece of equipment or something laying on that patient. So those are some important things to keep in mind. And remember, we talked about this earlier, is that by failing to provide appropriate positioning interventions, it could be considered neglectful of our patients, and certainly we're responsible for that as well. So I was talking about a way to kind of check post-procedure. So after you've done with the procedure and you're checking your patients before you transfer them to the recovery area, you want to look at their skin. And if you see areas that are reddened, what you want to check for is blanching. So we know that if you touch a reddened area and it turns white, and then you let go, you press it, it turns white, and then it refills up again. That's called hyperemia, and that's pretty normal, and there's really typically no damage with that. But when you touch an area and it doesn't blanch, so it stays red, then we need to be concerned about that. And that's information that you would want to make sure that you that you document, number one, and that you relay to your other individuals that are caring for that patient, so they can avoid getting any pressure. They can avoid the patient laying on that area as well. And then, of course, we want to make sure that we document appropriately in our record, the skin condition, what we did to position that patient. And if you're starting any kind of a program, the important thing is really to educate your team around proper positioning, how you track injuries, how you report them, and how you collaborate. And I would say that if you're going to start a team, I would definitely involve your wound care nurses, your infection preventionists, call for people on that team, that your frontline staff that are going to be able to, have some that are going to be able to help kind of establish a good protocol for you to develop. So next we're going to move on to the surgical site risk equation. We're going to talk a little bit about surgical site infections and then what we need to understand around that. So we know, of course, that surgical site infections are the most common health-acquired infection, and they're associated with the most cost. They occur between 2 and 5% of patients undergoing inpatient surgery, but we don't have data really on the outpatient population. So you can imagine that that certainly would add to that number. And if we look at just at inpatients themselves, if we look at about over 10 million patients undergoing surgery every year, that equates to about 200 to 500,000 surgical site infections per year. And our research shows that if we employ kind of best practices, and they're always multifactorial approaches, that we can reduce that risk. And while this particular information says 60%, I think our goal really should be, working towards zero, right? That do what we can do to prevent that. And so that really a couple of things we need to understand really has to do with the patient, the risk of the patient's own skin. Again, we're going to talk about skin and what we need to be understanding about it. So the number one risk factor is contamination from the patient's own skin. And we know that includes both the nares and the oral mucosal cavities, as well as our skin. And while there's about 1 million bacteria per square centimeter, it can take as few as 10 microbes per square centimeter to cause a surgical site infection. And that's data that we was based on orthopedic study on orthopedic procedures. So that makes sense when an implant's involved, that it can be even less than anything else. So if we can reduce that number of microorganisms, then we really can reduce the infections, the risk of the patient acquiring an infection. And so I'm just going to run through this equation because I think it helps us understand what we're going to talk about. So this is a surgical site infection risk equation. It actually has been out for a while, but it's a conceptual model, so it's not like you put numbers to it to determine an exact risk for a patient, but we can do that, and we're going to do it just to kind of visualize it. But it helps us understand that when we look at surgical site infections, we look at the dose of the bacteria times the strength of the bacteria, and then we have to look at the resistance of the hosts themselves. So if we look at the resistance of the host, that really means what can we control, or what do we know about that patient that can be something that we can control to help reduce that risk or increase their resistance. And then what can't we control? Well, some things we can't control, of course, are their age, their nutritional status. We can't control their weight, but we can control, if they're diabetic, we can make sure their blood sugars or their glucose levels are under control. We can understand what their core body temperatures are. We can make sure they're saturated, their oxygen rate, they're saturated in terms of perfusion. We can also understand, is there some decolonization that we can do? So those are some of the things we can control about that patient. Basically, our goal, if the situation is there, we want to make sure that they're as healthy as they can be when they come to surgery, when that's possible. The dose of the bacteria is really something that we really have a lot of strategies to control here. So we're going to really focus on patient preparation here. So there's things that we can do to reduce that dose of bacteria on that patient's skin. We'll talk about some of those coming up here. Obviously, our staff can prepare themselves for surgeries and follow, protocols and our environment, and really is something that we pay a lot of attention to reduce the risk of bacteria as well. So again, although it's not an actual number, I think it's helpful to understand this. So if we gave assigned numbers to each of these, so the dose of the bacteria times the virulence, we'll give them 4s times 4 times 4 equals 16, and we'll give the patient a 4 divided by 4 equals 4. So say that without doing anything, their risk is a 4. But if we do things to reduce that dose of bacteria and we bring it down to a 2, we make sure we prep them properly, we make sure that they're that the environment's clean. We do all these things to kind of reduce that load of bacteria. Now 2 times 4 divided by 4 equals 2. We've reduced that risk for that patient. And likewise, if we look at that resistance of the host, if we do something to build that host up, we control their blood sugar, we decolonize them, we make sure that they've stopped smoking. We've done all these things to kind of help increase the resistance. Now we've reduced that risk even lower. So that's just important foundational information for our staff to understand, that we can really play a role to reduce the risk for our patients just in the work that we normally do. So control what you can control. So one of those things really has to do with maintaining normothermia. Oops, excuse me. Sensory perception is really, and thermal regulation are the two functions of the skin that play a role here, right? Sensory perception, if you're awake, you would be able to tell if you're cold or too hot. And then those receptors would be activated as well. But that changes, right? So do you have a warming protocol for your surgical patients? Yes or no? Or only specific types of surgery? That's your next polling question.
Okay, I'm closing it now. You have 68% who said yes, 11% who said no, and 21% who said only specific types of surgery.
That's excellent. That's excellent. I'm glad to hear that you have that protocol in place. For the majority of you do, so that's great. So there are some negative outcomes for inadvertent hypothermia, perioperative hypothermia specifically. We know that if the temperature drops, this is a well-studied area that there can be problems for our patients, and those are related to increased rates of wound infection, increased mortality rates. We know there's problem with bleeding, coagulopathy. Our drugs can be prolonged or altered if somebody's too cold. Of course, we're familiar with shivering and thermal discomfort, cardiac issues, and then a delayed response and emergence from anesthesia can be a problem as well. So we know that this is an area that definitely there are some complications or negative outcomes, and so that's what we really want to make sure we're addressing for our patients. And so what's the #1 cause of hypothermia in surgical patients? Well, the induction of anesthesia is. And that's something that we don't always think of. We think of the patient becoming too cold because the temperature in the room's cold, or we think it's because we're using irrigation or there's too much body exposed. But really, 81% of the time, it really has to do with the induction of anesthesia. And that really is the most significant contributor to hypothermia. So when we think of, it's helpful to understand the normal thermic state, and that body's ideal thermal temperature is roughly around the core itself is around 37 degrees. And there's a temperature gradient between our periphery, our fingers and toes, and our core, and that's about 2 to 4 degrees centigrade. And when we're awake, our hypothalamus is really what regulates our core temperature. That's our thermostat. So what changes, right? What happens when we're asleep? And that's really where our skin no longer is helping us get that information to our brains, and that's when we really have to take over for our skin at this point in time. And that's because the anesthesia itself causes vasodilatation, or an opening of the arterial shunts. Um, the opening of the arterial shunts. And so what happens is the core warm blood now flows to the periphery, and it cools, it mixes with the cooler blood, and then that cooler blood goes back to the core, and that cools us down, the core down. So this particular process is known as redistribution temperature drop, and it's really the #1 cause of that is anesthesia, and that's not just general anesthetic patients, but regional anesthesia as well. And so it's important to understand what we can do to prevent that. And that really has to do with um, pre-warming our patients, and that by pre-warming our patients, we minimize that core temperature drop. So we add heat to our periphery preoperatively using either the warming, some type of warming device, warming blankets, or whatever your facility is using. And by warming the periphery, then when anesthesia occurs, we're now mixing warmer periphery blood with the warm core blood, and we're not seeing that, we're reducing that impact of redistribution temperature drop. So by reducing this temperature drop through pre-warming, in addition to intraoperative warming, these two practices are really what prevents hypothermia, and they're considered best practice for our patients as well. So it's important when you're managing your patients that you understand what your baseline temperatures are, and that you use that same modality of measurement throughout that perioperative journey. And then you pre-warm that patient in surgery. And this is, again, I said, any patient receiving any neuroaxial or general surgery or combined, they should be pre-warmed with active warming device. And then the amount of time between pre-warming the patient and when you begin intraoperative warming should be minimized as well. So we'll talk a little bit now about microbial load function, or the microbial load and reducing microbial load. And so what we're talking about from a term, the skin is really, we're talking about the protective layer, right? In surgery, we're going to impact that protective layer. Immunoregulation is something where the skin function that's impacted, and then microbial symbiosis as well. So this is kind of what a surgical site infection, some of the pictures of surgical site infections, and this is what we really want to avoid, right, for our patients. And unfortunately, these are not things that we always see. If I asked you right now how many of you have taken care of a surgical site infection patient or known somebody that's had one, I bet the majority of you would raise your hand. So I think you understand the impact that these infections can have on our patients, and why we want to avoid them, obviously. So when we look at the methods to reduce microbial load, we're looking at preoperative bathing, nasal decolonization, surgical skin antisepsis, and the creation of a sterile field. We'll talk a little bit about each one of these. So preoperative bathing and nasal decolonization. Interestingly, the CDC core strategy was updated in March of this year, and they really support the reduce Staph aureus device and procedure related health-acquired infections. They recommend a universal decolonization, which includes nasal decolonization and then the CHG washes or wipes. And these specifically is a core strategy for high-risk surgical patients, ICU patients, and then any non-ICU patients that have central lines or midline catheters. So that's one of the updates that was just done in March of this year. And we perform, of course, CHG wipes or bathing because we want to really decrease that microbial load on the patient's skin prior to making an incision in that skin, right? And so by doing so, we can reduce obviously the risk for that patient as well. So many of our services or our service lines have some preoperative bathing protocols before the patient even gets to the hospital, and then we may add to that as well once the patient gets to the hospital, in terms of CHG wipes or some kind of bathing within the hospital itself. And we know that that CHG actually wipes are effective, or some type of bathing is uh, is is important, and it can be more effective obviously than soap alone as well. And then decolonizing the nose, and why we want to do that. Well, we talked about, the #1 cause of surgical site infections is the patient's own skin, which includes the oral cavity and the nares as well. And so 30% of the population carry Staph aureus in the nose, and about 30% of them are intermittent carriers, and then the other 30% are non-carriers. And we know that 80% of Staph aureus infections have been traced back to the patient's own nasal bacteria. And in this particular study that was published in the New England Journal of Medicine, they did nasal screenings for patients prior to the surgical procedure, and then of the patients that ended up with a surgical site infection and those that they had samples for, they compared them, and they were known as paired isolates. And in over 84% of those Staph aureus strains that were isolated from the nares were identical to those isolated from that particular patient's surgical site infections. And so, that's one of the studies that shows that there's a strong correlation between the nasal bacteria and surgical site infections if patients get it. So that's an important information to understand. So there's options for nasal decolonization: intranasal mupirocin or povidone iodine nasal antiseptic. These are what are acceptable for decolonization. Mupirocin is twice a day for 5 days prior to surgery, and you're usually screening the patient to see if they have it, to see if they're positive, and then you do the treatment, and then you're supposed to rescreen again. Povidone iodine, there are some that are formulated specifically for the nose or the nares, and those have been shown to be as effective as intranasal. This has been shown to be as effective as intranasal mupirocin. With mupirocin, the issue obviously is compliance, in terms of, is a patient doing it twice a day, 5 days before surgery? Sometimes that's hard to remember, or is it hard to even get that prescription filled? Whereas the povidone antiseptic can be done the day of surgery, and you can be there to either apply it or observe. And of course, an antiseptic you're not concerned with an antibiotic resistance or as well. So we know that nasal decolonization, when that's part of your preoperative protocol, there have been studies that show reduction in surgical site infections with that part of that CHG bathing and nasal decolonization protocol. So those strategies, again, if you want these slides, you're certainly welcome to ask Linda for them, and we can certainly get you a copy of them. But there's a lot of stuff that you can read here in terms of, the effective strategy for reducing both catheter-related bloodstream infections and SSIs as well. So I just want to touch briefly on surgical preps, and I know this is information that everybody is very familiar with, but I'm going to talk about a couple things. It's important for staff to understand, what they need to do when they're selecting preps. They need to understand the patient factors, obviously sensitivities, allergies, the age of that patient. For example, if they're under 2 months of age, then an iodine-based prep is not recommended because of the risk of hypothyroidism. Likewise, if they're sensitive to any of the active ingredients, and you want to make sure that you understand what those are so you can select the appropriate prep. Always understand what the coverage areas are of your product, and then how they react during a surgical procedure. Are they easily washed away? Do they maintain their effectiveness? That's important for your staff to understand. But I wanted to talk a little bit about some data that I think is interesting, because I think everybody thinks we do prep really well, but I think there's areas that we could improve upon. And we do a prep and drape checkup uh, where we offer, you know, and kind of being coming as audit or observational evaluation for facilities. And this is some of the information we found on that. It's all based on the guidelines in terms of the AORN standards for prepping and then manufacturer's instructions. And so these are some of the things that I pulled off. This was after 64 prep and drape checkups, and they were done between 2017 and 2019. And this is the percentage of time that the guideline was not followed. So did not select the appropriate prep, 31% of the time. Did not follow instructions for application time, 69%. Did not follow instructions for manufacturer's instructions for application method, 92% of the time, and did not follow the IFU for dry time, 78% of the time. And then these really, they did not protect the patient's linen when prepping, 91%, and did not follow antiseptic practice, and that was only 16%. But what concerns me has to do with, you know, the effectiveness of the prep. If you don't follow the application time, application method, or dry time, that impacts the effectiveness of the prep, and ultimately can impact the outcome for the patient. Likewise, safety, if you don't follow dry time and you're not protecting that patient from that solution pooling under them, that can impact that patient's safety as well. Not only from a fire risk, from a skin irritation risk as well. So make sure that you protect the patient from pooling of solutions. Make sure that your staff understands the proper instructions for applying that product. And any of the products that you use, the reps will certainly come in and do in-servicing for you. And this is, even though we think we have it down pat, I'm telling you, it's not. It's not a bad thing to review on your annual reviews. And then understand the importance of that risk, reducing risk of fire, and also skin integrity and irritation by making sure that prep is dry if you're using, and not just alcohol-based prep, but any prep. And then finally, creation of a sterile surface. We know that we can't sterilize the skin, and there's always going to be some bacteria that remains on that skin. So if we think about it, you know, is there something that we can do to protect the patient after we've prepped them? And so because we can't sterilize that skin, there's always a chance of introducing bacteria into the skin or into the incision after the surgical procedure has begun. And so we can create a sterile surface on the patient's skin. First, we prep them. As I said, we let it dry. We put our surgical drapes down to create the sterile field. And then when it's appropriate, we can add a sterile incise drape to create that actual sterile surface on the patient's skin. And that really creates it all the way to the wound edge, and it decreases the risk of residual bacteria or microbes being transferred into the incision. So we know that there are drapes that you can use that have that are clear film. It's an adhesive that you place over the actual kind of draped out area, and there are some of those that also help. They have an iodine in it, which helps keep that residual bacteria under the drape itself low as well. Guidelines around that really support the use. If you're going to use one, they support the use of antimicrobial incise drape, and the AORN just changed their standard statement on that in 2018. And then this is just one study that I wanted to quickly talk about, and this just really talks about why we do it. And it really has to do with in this particular study, this was done by Dr. Rezpour and Associates, and it really looked at the contamination rate at the incision site versus using an antimicrobial drape and not using one. And so they took cultures at 5 different time points, and what they found was that the incise drapes, the patient that had no incise drape, they had contamination rate of 27.4% at the incisional area versus ones that had the antimicrobial incise drape, which was at only 12%. And so what they decided was that, you know, at that point, they weren't even hadn't completed the study at that point, and they decided to terminate it because they felt that they were putting their patients at risk for continuing without using incise drapes in that randomized controlled trial. So finally, and I apologize, I'm going a little long here, so I understand if you have to drop off. But finally, I want to talk about our wound management. Um, and really what we're looking here has to do with protection. We want to support that self-repair of the skin when we look at wound management. And so the first thing to consider really is, we close wounds in one of three ways. They're either primary intention, secondary intention, or tertiary. Typically, we see most often is primary intention, and it's done immediately after the surgical procedure. It promotes fast healing and kind of a normal healing pattern, and it really the focus on this closure is really protecting that incisional site and until the patient actually heals. And we know that if we look at the actual surgical dressing, there was a Cochrane's meta-analysis that looked at all different ways of protecting the wound, and what it showed us was the goal is really to protect the wound bed, to keep it the wound bed moist and the surrounding tissues dry, contain the drainage or the exudate, and minimize the dressing changes. These are all certain things that are important. And the only main guideline that we have around it really has to do with the CDC guideline that looks at preventing SSIs, and it's really to protect a primary closed incision with sterile dressing for 24 to 48 hours. That's kind of the most recent recommendation. And so when we look at dressings, we certainly we all know about gauze and tape, and that's probably our lowest level of dressing. It certainly provides absorption. There are many levels of dressing, and we want to look at kind of what's going on in that wound and what we need to protect the patient for in that healing process. So you need to select the dressing that's going to be most appropriate for that patient's incision and what we expect to happen. And so the other thing we need to consider is really the medical adhesive that we're going to be using. And I don't know if you've heard of the medical adhesive related skin injuries, or MARSI is the term for it, or the acronym for it. And there's really three different types that we see mainly in the OR, and it really has to do with skin stripping, tension injury or blisters, or skin tears. These are the ones that we most often see in the OR. And interestingly, orthopedics is really the most common culprit in relation to medical-related adhesive injuries, MARSI injuries, because of the amount of tape that's used, and then the swelling and movement and that occurs in most of these surgeries. So one particular study showed that there was an incidence of tension blisters have been reported as high as 41% in patients with hip surgeries and 6% following knee arthroscopies. This is one particular study that we referenced. So we want to really make sure that that we're selecting tape that's appropriate for that patient and applying it in a manner that's most appropriate as well, no matter what type of surgery they're doing. So if tape is used, we know there's many uses, and you make the appropriate selection based on what you're going to be doing, right? But you would do the same thing for our surgical tapes as well. So understand, when you're going to need gentle securement, when you're going to need general securement, what's going to be needing flexible securement, and then are there situations where you're going to have high securement? Of course, some of these examples here kind of help us understand that. And then, of course, we want to make sure that we prepare that skin before we put any tape on. And for some patients, you may need to use kind of some kind of a film that you put on, a barrier film that you use prior to putting tape on, especially if you're going to be doing frequent changes. And then when we're applying our tape, we want to make sure that we don't stretch it, that we just lay it on and smooth it over. And this is true for any kind of adhesive that we're using on patients, that we just want to lay it on and then smooth it over, and that helps keep it from strapping and causing that blister-like injury. And then to keep from causing those tears or denudation of that skin, we want to remove it. We don't want to rip it when we take it off. We want to remove it with that low and slow type of method, and that's really going to help reduce that injury to the patient as well. So with that, I just want you to consider, what kind of dressing and would you pick for this patient versus what you might pick for someone like this. That's really going to be kind of determine what decisions you're going to make. And if you have questions about that, your wound care people might be good people to bring in and help kind of go over tape and dressing applications with your staff if you've got kind of a new group of people. And actually it's not any training that I had when I started in the OR, so I think it's good to call in some additional help when you can. So we've talked about a lot of stuff, and I apologize for running a little long. um, and what I want you to think about really is whether your patient's skin looks like this or like this or like this. How well are you protecting that patient's greatest line of defense? So with that, I will close, and I know we won't have time for questions, but if you do have some, I'm happy to answer them offline as well. So thank you so much for your time. I appreciate it, and this is my contact information if you should have any questions for me at all.
Great, thanks so much, Kimberly. I can squeeze one question in if that's okay with you.
Sure.
The question I've got is, I've heard of hospitals instituting skin champions or a skin team. Have you had experience of working with this type of group? And if so, who staffs it?
That's a great question, and what I will tell you is that there's a couple of examples I have where the team actually was put together by the OR. They started it because they had gotten some information from their wound care people that they'd had kind of a series of patients that had come to the wound care team with some pressure injuries post surgical procedure. And these, like I said, sometimes don't occur right after. You're not going to see them right immediately after surgery. So based on that information, this particular OR gathered individuals. Their nurse educator was part of it. They had someone from the wound care team be part of it. They had some frontline staff, and they kind of all worked together. Anesthesia was part of that as well, to kind of start a team, a skin care team, so they could start that protocol in their department. And they did a lot of education around assessment and positioning, and they kind of took baby steps to get all that information in, and then they made sure they understood what type of data they were going to collect and then how to report on it. And I think the important thing for them is that they kept their staff aware of where they were with their incidences, and they showed great improvement with reduction of pressure injuries after this team got underway and everything got put into place. So that's kind of the experience I'm familiar with, that I think it was kind of a good model to follow as well.
Okay, that's great. And as Kimberly mentioned before, if you do have any questions, please do not hesitate to contact her. Her email address is on the last slide, as you can see. Well, we have come to the end of more than our hour. So thank you so much, Kim, for a great and informative webinar. And thank you once again to our sponsor, 3M. Just another quick reminder that the post-webinar survey and certificate process is automated, so the survey link will be included in the follow-up email, which you'll receive in about an hour's time. If you have any questions, please contact us at webinar@mdpublishing.com. And for more information on our upcoming OR Today webinars, please visit our website, ortoday.com. So thank you again for joining us today. Enjoy the rest of your day, and we hope to see you next time.